such good information, and I think it's going to continue. One of the areas of comorbidity that's been talked about for a long time with HIV is cardiovascular risk. And I don't think there's much question that we see at least more and probably a different variety of cardiovascular disease in people with HIV infection. And one of the studies that was designed years ago now to address that, a very ambitious study that Steve Grinspoon from Harvard put together, looking at statins for HIV-infected people that were not at high risk by the usual kind of metrics for cardiovascular disease, was the Reprieve study. And well, we've seen that now for about the past year or so, but it's been a complex and still evolving data set. And to walk us through that, we have Judy Aberg. Judy is a professor of medicine. Again, I'm looking at the crib sheet here. She has, in the way of academic medicine, some people go to some serious administrative roles, and she's taken on a number of them at Mount Sinai in New York City. She's the system chief of infectious disease, probably not just a local division, but divisions that go across the various sites of Mount Sinai Health. She is a named professor of medicine at the Icahn School of Medicine at Mount Sinai, and has taken on a number of administrative and mentoring roles looking at the spectrum of clinical and translational science there. And I know she is also a very active investigator, and we look forward to your talk. Judy.
We always have to hug because Paul gave me my first faculty appointment at UCSF, so many thanks. So many thanks to the organizers for inviting me, and it's really great to be in person here in Chicago. It's been a number of years, so thank you all. Many of you too young to know about this song, Young at Heart, which was an old Frank Sinatra song, but it also was the 2016 Olympics Gatorade theme, that your dreams can come true if you're young at heart. So these are my financial disclosures. And learning objectives, we're going to talk about how HIV impacts cardiovascular health, and I'm going to go over the results of Reprieve in depth and how it may influence our clinical care today. As way of disclosure, I am one of the vice chairs of Reprieve, so there could be some bias here, and I acknowledge that. So Roger went through some of this already, but HIV infection, even when it's controlled, is associated with chronic immune activation that's superimposed upon immunologic senescence, especially in the older adult. And there is a less robust, immunologic response to antiretroviral therapy in the older patients. And many of you see this, Your older patient, you start antiretrovirals and their T cell count just doesn't come up like you see in younger people. And persons with HIV accumulate these age-related diseases at a younger chronological age, and these conditions now account for the majority of deaths, especially in resource-rich countries. In the United States, fortunately, we're not seeing people die from AIDS like we did in the past decades, but we do see them dying from these comorbid conditions. And people with HIV have a twofold increased risk of major adverse cardiovascular events, which I'm going to call MACE throughout, compared with the general population. So this is a word that I love, inflammaging. I was so envious. I wish I could have created that name myself. But the point being that all these different conditions that we have, it's really there's this underlying chronic inflammatory state that goes on to lead this. And the reason I bring it up is I was sitting on my couch watching the news, and CNN talked about inflammaging. And I was like, oh my God, what? So what's going on? So there's been a lot of interest in pheno-age, and Roger talked about epigenetics. Well, there's a way now that they've proposed to look at your biologic age versus your chronologic age based on laboratory parameters. And a lot of this has been sparked because of the younger individuals now getting cancer. So, we had Bosman that had died from colon cancer, 43. There, Aiden Canto just died this past year with, again, another colon cancer at the age of 42, and Kate Middleton now diagnosed with a cancer at age 42. And so this really has hit the news about what is it that younger people now are having cancers at a younger age than people older than them. So this group looked at over 148,000 records in the UK Biobank, and they looked at individuals aged 37 and 54 and compared that to older adults. And so they run these laboratory parameters here. They're all common labs, right? Albumin, creatinine, glucose, C-reactive protein, et cetera. So there's 9 laboratory tests. Unlike genetic tests that cost a lot, you guys can Google right now, do PhenoAge, it costs $75. They'll run your blood and they will tell you what your biologic age is. But what was interesting that these investigators found out that there was much more comorbid conditions in people that were younger compared to those that were born like in 1950 through 1954. There was a 42% increase in lung cancer, 22% increase in GI cancers, and a 36% increase in uterine cancer. So what's going on that all of a sudden we're seeing younger people, we might say middle age, in their 40s getting these diseases that typically were affecting those over the age of 50 and 60. So this, again, is an older cohort. This is the geriatric patients with HIV in a prospective observational cohort study called GEPO in Italy. And I like this presentation that they did before because it really highlights where this 10-year gap comes from. And so when you look at the cases being those with HIV versus controls individuals without HIV, if you look at the columns here, like at 41 to 50, and you look at these breakdown, 80% with no comorbid condition, 17% with one, and then you look at, well, that's the people that are less than 40 with HIV, and et cetera. So you look up here, 51 to 60, and this very much is similar to the people that are 41 to 50. So really the percents are off here by about 10 years. And when you look at the population greater than 60, look at the number of individuals with 2 comorbidities, 3, and even 4, compared to those greater than 60 here. So clearly showing in this cohort in particular that, there's about a 10-year difference. The same group also, I thought, did something very interesting because if we're going to say that this chronic inflammation is due to immune activation from HIV, it makes sense that it would be related to the duration of HIV. So what they did is they looked at people without HIV, individuals with less than 10 years of HIV, 10 to 20 years, and then greater than 20 years. And look at how this is. This is dyslipidemia, chronic kidney disease, type 2 diabetes. You see that increase for the longer you have HIV, how that risk goes up. And they're continuing this cohort, and every year we kind of get a little glimpse of their updates at various conferences. And so to date, it's really holding true. So there's a lot of factors that go into why does somebody develop cardiovascular disease. And in the past, we used to concentrate so much on the metabolic side effects of antiretroviral therapy, and they're better, but they're still contributing some. And then you have the contributions from HIV itself, and then, of course, behavioral risk factors. It was mentioned previously about our patients still are smoking at a greater incidence than what the general population is. And then you have the things that we can't change. So I want to go over the background for Reprieve because we developed this protocol in 2013 and 2014. And so a few things have changed since then, fortunately. but some things haven't. So the risk of MI and acute coronary syndrome still remains elevated, with a relative risk of 1.5 to 2. It is unique in HIV in the fact that we see this often happening in asymptomatic younger individuals, and they may not have traditional risk factors. What they have is HIV. And at the time, there was no current recommendations for the prevention of CVD in HIV, which considered the unique pathophysiology of atherosclerosis in this population. So people ask me, why did you choose a statin? So statins, as we know, their primary effect is to lower LDL. But there's always this, what is magic about statins, right? These pleiotropic effects. So they are anti-inflammatory, they're antithrombotic, they're immune modulating. And so what we see is you see reduced oxidative stress, you have increased endothelial function, improved vascular tone, as well as you have plaque stabilization. So many reasons why to choose statins as a medication to prevent cardiovascular disease. Then the other question I get asked is, why pitavastatin? Nobody even heard of pitavastatin. And I didn't either. We were in clinic, and one of the endocrinologists came over and said, why don't you use pitavastatin? There's no drug interactions. So we went on to do drug interaction studies, and there wasn't any. And so when you're doing a randomized controlled, placebo-controlled trial, you needed to be able to give a blinded therapy and not have to worry about dose adjustments. So you couldn't do a blinded study with atorvastatin or rosuvastatin, which were, for the most part, the preferred statins, and pravastatin had a significant drug interaction with darunavir. So that's how we wound up selecting that pitavastatin would be the drug of choice to do in a placebo-controlled trial. So the primary hypothesis of Reprieve was that it will prevent atherosclerotic cardiovascular disease-related MACE in people with HIV on antiretroviral therapy who are at low to intermediate traditional CVD risk. So individuals who did not have a clinical indication to be on a statin. And the secondary hypothesis was that statin therapy would be associated with specific events. There would be decreases in LDL and non-HDL associated with a statin therapy and would be predictive of that reduction in events. And that statin therapy would also reduce other non-HIV related and non-cardiovascular events, including malignancies, kidney disease, liver disease, and that statin therapy would be safe and well tolerated. So this was a global study. Individuals had to have a CD4 count greater than 100, receiving stable antiretroviral therapy between the ages of 40 to 75, selected because that's what the 2013 ACC and American Heart Association guidelines are for. And if you look, these are the risk scores at the time. Now this has changed, but remember, it was 2013. So at the time, this is who would have gotten a statin, individuals that had a risk score, less than 7.5 LDL and less than 190 would not have an indication to be on a statin. Similarly, people that had a risk score of greater than 10% to 15%, if their LDL was less than 130, they didn't need to be on a statin. So that was the population that was selected at the time. Almost 8,000 individuals were enrolled, equally between placebo and pitavastatin. Again, primary endpoint being the MACE, and secondary endpoints including biomarkers, all-cause mortality, et cetera. And then we had this mechanistic substudy embedded in here, which was looking at coronary plaque as well as vascular inflammation, immune activation markers. And of the 805 that were enrolled, 755 had a baseline coronary CT angiography that we could follow. So this was the hypothesis for the mechanistic substudy. Again, the mechanistic substudy was designed to assess whether the strategy of giving a statin on plaque and key inflammatory and immune markers showed that there definitely was a benefit. And so the study objective compared these plaque features, including stenosis, coronary artery calcium, which is called CAC scans, vulnerable plaque, and Lehman scores across the CVD risk strata as determined, again, remember, we're going back in time by the 2013 pooled cohort equation. Now, Lehman score, many of you may not be familiar with. I certainly wasn't. It's a radiologic tool calculation that's based on where the location of the plaque is, the type of plaque, as well as the degree of stenosis. And so they calculate that out. And Lehman scores have been very predictive of events. And then we compared the key biomarkers, the usual immune activation markers and inflammation, LPPLA2, oxidized LDL, and high sensitivity CRP. So our hypothesis was that coronary plaque would be prevalent among people with HIV with low traditional risk and relate strongly to these key markers, suggesting the importance of targeting these pathways as a way that we could prevent CVD. These are the baseline characteristics, just a few things to point out here. One is the age. When you look at most statin studies in general population, the median age is 60. This is a young group, it's 50. It's 31% female, 41% Black, 15% Asian. They had really excellent CD4 counts when they came in. Remember, these are people that were, for the most part, suppressed, so they had well-controlled HIV. But I want to point out here, you look at nadir CD4, 50% of these individuals had a diagnosis of AIDS at some time. And you can see, again, they're well-controlled. And the risk score was low, right? 4.5%. Nobody would normally give somebody a statin with that low risk. And I'll point out that women, their median score was actually 1.9, so very low risk. And then the LDLs were low. You got a median here of 108. And these are the primary key endpoints that probably most everybody in the room is familiar with, is that we found a 35% reduction in MACE and a 21% reduction in MACE or death. So really striking results, and I say that because now there's been studies with the GLP-1 agonists as well as the GLT-2 agonists, and their percent reduction in MACE is significantly less than what we found with the statin. Now, some have now said, why don't we start combining them? But I don't know that we're ready for a Reprieve 2. I don't think my heart could take it. All right, bad pun. Okay, other key findings, only 1% versus 0.5% withdrew because of myalgias. And diabetes rates were higher. They were 5.3% versus 4% in the Pitava versus placebo, but that's consistent with other studies that have been with statins. But I think the drive home point here really is you had a 50% reduction in MACE among the diabetics. So that benefit, right, outweighs that potential risk. And just to go over what the actual reduction was here, you can see that the LDL started at 108 and then went down to 77 on pitavastatin. And similarly, you see this great reduction with non-HDL. What I really want to point out, and I find very interesting is, and I was at one point the chair of the HIV MA primary care guidelines, is we said get lipids every year. You got 6 years of data, and those lipids are really stable, right? And these are people with normal range LDL. So the general population recommendations is you check lipids every 5 years. So I wonder, do we really need to be checking lipids every year in somebody that has a relatively normal LDL? And you see that your response is pretty much what you get at 12 weeks on a statin is what you're going to get, and it's stable, right? So it's very durable. But I want to go back to this about one of the secondary endpoints about, being just about LDL lowering, that it was going to correlate with it. So this was a study that was published in 2010 looking at all the various general population lipid lowering studies. And so this is looking at what is your reduction in your LDL. So I just told you we had 108 and went down to 77. You have to convert it to standardized international units. And when you do, that's about a 0.8. So based on just LDL lowering activity alone, you would have predicted in Reprieve that we would have had a 17% reduction in MACE, yet we reported a 35% reduction. So what is it about statins that they're doing, because it exceeds what you would have expected just from lowering somebody's LDL? And this is a number needed to treat, and I think this is really important, especially when you get into shared decision-making about whether or not to start a statin. Clearly in people, the higher your risk is, right, the less the number needed to treat is. So really, really strong numbers. But even in this group that's 0 to less than 2.5, it's 1 to 187, right? For every 187 individuals, you prevent one event. Just remember that in some of the other statin studies, even to prevent stroke, it's 1 out of 300. So that number is still pretty high, even though it's not what obviously the benefit is when your risk is higher. This is the baseline results of the Mechanistic substudy, and I just want to orient you here, but on the bottom here is your ASCVD risk score of being less than 2.5%. Less than 5%, less than 7.5%. And again, not surprising, right? The higher your risk score is, the more burden you're going to have of plaque, your calcified plaque, your non-calcified plaque, this Lehman score that I mentioned, every parameter here increased, right? Not surprising. But this is, I think, where the money is that overall, 49% of these individuals in Reprieve had plaque at baseline, and 35% had a positive CAC, and 23% had that vulnerable plaque, and that's the plaque that ruptures. And when you look at these individuals, why would you put them on a statin? It's less than 2.5%. 30% had plaque, 22% had a CAC greater than 0, and 13% had that vulnerable plaque. And here's the effects on the plaque. So we saw regression of the plaque volume and, less progression in those that receive pitavastatin. I think it's a little bit easier to see on the pie charts here, where you can compare and you can see the amount of regression that we saw in plaque on pitavastatin compared to placebo. And again, you see more progression of plaque on those on placebo compared to what the progression was with pitavastatin. These are the biomarkers, so everybody wake up from lunch. So, quiz. So, we did see a significant decrease in LP-PLA2, right, and oxidized LDL. And those are both important. LP-PLA2 is a platelet activating factor, and oxidized LDL is kind of in your entry in atherosclerosis and, in come the foamy cells. So those two things are very important, and they were significantly decreased. But that CRP, IL-6, not so much. So it really was pretty flat we looked at a bunch of markers. We still have a lot more coming, and we're doing proteomics as well. So we hope that we're going to be able to find more, what pathway maybe can we target so we can really understand this pathophysiology more. So in conclusion of the Mechanistic substudy, people with HIV with low CVD risk scores have this unique plaque phenotype with this vulnerable plaque, right, non-calcified plaque, with increased overall plaque, which relates strongly and independently to markers of innate immune activation and arterial inflammation. And 24 months of pitavastatin led to that decrease in non-calcified plaque volume overall by 7%. And remember, I showed you the 49% like at baseline that had it. That led to a 12% decrease in non-calcified plaque volume. And we saw a decrease in lipid oxidation and the arterial inflammation. And so we're hoping that the understanding of that this will lead us to understanding other pathways that may be useful, right, in future studies and useful for our patients. I just want to take a minute to talk about biomarkers of inflammation and coagulation because we still don't really know how to use them. Persons with HIV have increased levels of CRP, TNF-alpha, IL-6 dimer, soluble CD14. I can go on, all the markers that are high. And these elevations, though, persist even after virologic suppression. We saw that in SMART and START, likely due to this HIV-induced activation of inflammation and coagulation. And the levels of these pro-inflammatory cytokines are associated with HIV viral load, right? We know that if you have high viral load, your IL-6 is really high, and they're predictive of disease progression, right? Again, some of the cohort studies have shown that, some of the really large randomized trials have shown that, and they correlate then with having these comorbid conditions like cardiovascular disease and all-cause mortality. But to date, nobody has been able to do an intervention that actually lowers those markers so that they're really useful for us to monitor and guide us on how to manage our patients. So what are the clinical implications from Reprieve and where are we going? So Reprieve results now have been incorporated in the DHHS, the American Heart Association, American College of Cardiology, and HIV/MACE CVD prevention guidelines. They've been accepted now too for Reprieve is being used for the British HIV guidelines. So other countries now are starting to implement, care management plans based on what Reprieve has shown. But we still need further work, and Roger mentioned this, that how do you use a pooled cohort equation when it underpredicted, especially among blacks and females? So that tool is not working, and we're hoping that Reprieve may be able to come up with a new calculation that will help us better predict what our patients' risks are. So we have a lot of future analysis going on. We're looking at the global burden of disease regions, genetics, lifestyle, and other risk factors. So I expect we're going to have many more papers coming out and hopefully can guide us. So this is the 2018 multidisciplinary guidelines that we've all been using, and we all agree that LDL is greater than 190, having diabetes or having greater than 20% risk, those individuals need to be on statins. In the previous rendition of this, and it's still current for the general population, if you're less than 5%, then, that was lifestyle intervention, right? No statins. And then you start getting this 5 to 7.5% that, well, maybe you should consider a statin. Look at risk enhancers, and we're really happy when they included HIV as an inflammatory state and one to consider. And even all the way up to just 19% was this, you probably should do a statin, but if you're uncertain or your patient doesn't want to go on, get a CAC, right? And if your CAC was 0, then they might not need a statin. And now the guidelines have changed, and the full guidelines won't be changing for a couple of years. So that is why we have this interim guidance from AHA and ACC along with DHHS and HIV/MA. Pravastatin is recommended A1 for both these two categories, with rosuvastatin and atorvastatin as alternatives, or an A2 recommendation, right? And if anybody can get pitavastatin, raise your hand. I still can't. So pretty much everybody's going on this. The C1 recommendation, so one is for strong recommendation for this group here, that they strongly recommend or favor starting a statin here, but there wasn't enough evidence when you think about long-term risks and benefits that this particular group felt that they didn't want to give it an A or a B recommendation. They gave it a C recommendation. So the question is, why isn't pravastatin on there? Again, wake up everyone, because that was one of the questions, right, is why isn't pravastatin there? Well, because we did a study once before called Intrepid, which was people with HIV with dyslipidemia who did need a statin, and it was blinded between pitavastatin and pravastatin. And this is LDL at 12 weeks, 52 weeks, and then your non-HDL and apolipoprotein B. And you can see that pitavastatin was superior to pravastatin, which is why it was not recommended in that current guidance. And I had nothing to do with that guidance. I bring this up about the imaging because, again, this is individuals with low LDLs, but they have high risk scores. So from Reprieve now, we would say these individuals should be on a statin. And so my question was, does Reprieve change that 2018 guidance? And then what is the role of a CCTA, right, the coronary CT angiography, rather than a CAC score? Would it be better in our patients with this vulnerable plaque and non-calcified plaque to have that imaging rather than a CAC scan? So the overall messaging from Reprieve is that statin therapy with lifestyle counseling should be considered for people with HIV, and I should say age 40 to 75, even those with low to moderate predicted traditional risk to reduce MACE and death. And for the decision to do this really is a shared decision-making. It shouldn't be based just on Reprieve alone. You have other factors that you need to consider. There's drug interactions, metabolic factors. Does your patient want to take an extra pill? What are the side effects and versus the benefits? And all these conversations should emphasize a heart-healthy lifestyle, ideal diet, counseling on the other risk factors that we all know, smoking, blood pressure, et cetera. So in summary, antiretroviral therapy has dramatically increased survival. There's no question about it. Patients have improved life expectancies, but they still have higher rates of these comorbid conditions. And there is evidence of cardiac disease, even in these patients that had well-controlled HIV with low to moderate risk. And so I think it's really up to us to inform our patients that these comorbidities may occur at a younger age and what ways that we should do to screen them for that and help protect them from developing them. And, Reprieve in general showed that pitavastatin worked, right? It was well tolerated, it prevented MACE. In that subset of people, right, it's the low to moderate risk and individuals that had normal range LDL. So the take-home points are that excess cardiovascular disease risk remains high. Individual aging, which I should have mentioned this more in depth, but I showed you how the duration of HIV changes. So individuals aging with HIV are very different from somebody that's been newly diagnosed with HIV, right? If you have somebody that's 50 years old and they were diagnosed at age 48, that's very different than a 50-year-old that was diagnosed at 20. And so they may have different CVD risk, and that may affect your decision on whether or not you want to start a statin. Your largest modifiable risk factor is smoking. There's many things contributing to cardiovascular disease. We should treat all our comorbidities as aggressively as we can. We need to improve and have a way that we can predict the risk score for our patients. And I didn't have time to go over this, but something that often gets missed is in diabetes, individuals with an LDL greater than 70 not only should be on a statin, but probably aspirin. While aspirin is not recommended as primary prevention in general population because of the risk of bleeding, in the two very large studies in diabetes, that benefit of aspirin outweighed that risk of bleeding. And so the new question is, should a person with HIV 40 years and older be on a statin? And I can't tell you that myself, but I just thought this cartoon was really good. The good news is your cholesterol stayed the same, but the research findings have changed, so what do we do? I just want to give a shout out to my own team and to the many individuals here that were Reprieve sites. It was a lot of work, and really want to thank everybody for all their contributions, and just innumerable thanks to the study participants themselves. So I'll stop there. Thank you.
Spectacular, of course.
I learned from the best.
Yeah, everything she knows. So what Judy didn't talk about, we heard at dinner last night, was her role at NYU, where she was working before going to Mount Sinai. I was there during the superstorm Sandy, and told stories of kind of carrying patients' lunch trays up 18 floors because the elevators were all off. So a real hero. As a non-HIV infected person, but a person who's been on statins for a very long time, I love the Reprieve results. In disclosure, I was on the DSMB for this study and monitoring the study. And I'd have to say at the start of the study, there was a fair amount of pessimism among some of us that this was going to work out. Another member of the DSMB was Carl Grunfeld, who's a historically kind of grim kind of guy, but we love him. But he was also quite skeptical. And I have to say that the study investigators did just an amazing job recruiting this study, giant study, over 5,000 participants, and in the face of the COVID pandemic, which happened along the way, we're still able to keep the study going and to come up with data that was, as Judy showed us, just completely amazing and pristine and kind of fact-checked in so many different ways. So lots of credit to a study that's been very important for, not just for our field, I think, but medicine in general. And just to continue my soapbox a bit, my own question coming up, kind of as a moderator, you often have your own question just in case the audience doesn't feel like asking questions. And my question was going to be, why don't we just all take statins? And of the questions that I got from the audience, that was like the first 2 of 3 was, why don't we just prescribe statins to all the people? And I have to say, looking at this and kind of looking at the impact, even beyond the LDL effect and the very low rates of side effects, let's ask Judy to expound on that. Why isn't it over the counter? Why aren't we just? I'm not joking. Yeah.
No, I think it's a great question, but I think, to say that every single person needs to be on it. Again, you look at, remember what I showed you, the number needed to treat, it does elevate. So you're talking about 1 out of 187, right? And trying to do that balance, I do think we still need to do shared decision-making, but, is it really going to be beneficial to somebody has a 1% risk? We don't know. And I think that's where the imaging, to me, has been interesting, when I have patients now that are on the fence about, we tell them what Reprieve showed and all. I do get a CCTA, and some of them, their coronaries are clean. There is no calcified plaque, right? Remember, half of them don't have it. So, but are we going to say that everybody needs to get a CCTA? So I think that's where some of the hesitation is, because when you're looking at the person that's right in front of you, you don't really know what their true risk is. And that's why we need a better tool to be able to assess what that risk is and who definitely would benefit.
So then let me ask another personal question that's also reflected in the questions that I have in front of me. What about people that are concerned about their risk for dementia? We've heard because statins are anti-inflammatory, is inflammation the whole story with everything that we face? Is that another reason that we should be considering this drug?
So it's interesting. There is a group at UCSD that has for years talked about how statins actually cause cognitive impairment. There's a talk about how it causes erectile dysfunction. I remember I was giving a talk in Florida, and the day that I was giving my talk was USA Today headlines talking about this group in San Diego, not Dr. Benson and the ID group, but talking about the adverse effects of statins. And so we don't have data yet that really, and Reprieve did not do an in-depth neurocognitive check to actually say, is this going to be beneficial or not? But it's a great question. We're getting asked that. And, we did so many sub-studies, but, we looked at physical function and, we didn't really see that it affected physical function either. So, I don't know. I can't guess what it would do for neurocognitive function.
Hard to estimate for sure.
Yep.
Question, have you looked at cardiovascular risk among lifetime survivors of HIV? Are young people aging even faster due to being on medications their whole lifetime? I think you sort of got to this at the very end of your talk, but talk more about this long duration of HIV management.
So I think the duration of HIV, as shown in that GEPO, that cohort, really is interesting because there does seem to be a big difference on the duration of HIV. Reprieve has not yet published or finished the analysis of looking at what the different antiretrovirals may do. So we are looking at, what the exposure was before you went on Reprieve, what the exposure was during Reprieve, and a lot of people switched. You think about when Reprieve opened in 2014, 2015, regimens changed, and so you see that shift of less people on abacavir, more people on TAF, from TDF to TAF, and then more people on integrase. So it's a very challenging data set to look at. So I'm as anxious of all of you to know what the results of that may show.
Great, great. Any questions from the audience? Okay. Maybe we'll thank Dr. Aberg and, oh, wait. We can still thank Dr. Aberg. We can also ask a question.
I just have one question. So where do you put abacavir in place in your treatment of people with HIV? Do you have you switched all your patients off it? Have you left your patients that were on it on it?
I think, when I look at overall in our clinic and at Sinai, we provide care to over 10,000 people with HIV, so it's really large. The abacavir use is very low, but I think there was a very large switch with the integrase and then with TAF coming out, that, the vast majority of starts is, just as you all voted, is using bictegravir, TAF, FTC. And so we see very little abacavir. I mean, I can't tell you the last time that I personally have prescribed it. It's just, it's really not used like it was before. And I think that's one of the things to me that's going to be interesting when we look at Reprieve, because being it is a global study, we will have more abacavir in those global, settings. And I think it's going to be important for us to look at what the differences are between the different regions.
Great. Well, we won't thank you again.
All right.
And we'll ask Connie to take it up.